Good morning and afternoon, everybody. My name is Lindsay Wolfson. I'm the research manager at the Center of Excellence for Women's Health, and I'm so grateful that today you're joining us for the How Sex and Gender Matter in Cannabis Use webinar. This webinar is going to be the same as many Zoom webinars before it. If you have a question, please put it in the Q&A function down below. This webinar will be recorded and the slides will be sent to all registrants as well as the recording, and it will also be made available on the Center of Excellence for Women's Health website. Before we begin, we'd like to acknowledge that we're joining from the ancestral, traditional, and unceded territories of Indigenous and Métis people of Turtle Island. We want to acknowledge the First Nation Inuit and Métis as the first inhabitants and traditional custodians of the land in which we live, learn, work, and play. Today, we're presenting from the traditional territories of the Haudenosaunee, Anishinaabe, Mississauga, the Credit First Nation, Mississauga, Wendake, and Winsento, and I'm here from the Muskogee, Yamasee, and Gwale territory. We pay our respects to the elders past, present, and emerging. And I also want to give my immense gratitude to the Gullah Geechee peoples who have a rich history here where I'm presenting in Savannah today. Today, I'm joined by a few of my colleagues, but not everyone who contributed to this team. Our research associate, Dr. Andrea Berbetti, will be presenting alongside me, and Ella Huber is in the background changing all these slides and doing an amazing job. If you have any questions for us, please do not hesitate to reach out. Ella is accessible, and we also have Doug in the background who is listed as support. So please message us if you have any concerns, and we will get back to you as soon as possible. I also want to acknowledge that this project was funded through Health Canada's Substance Use and Addiction Program, and the views expressed in this webinar do not necessarily represent the views of Health Canada. We also, of course, have no conflicts of interest to declare. So in today's webinar, we're hoping to walk through a little bit about sex, gender, and cannabis, what we know, and then think a little bit about how to apply sex and gender-based analysis. In this case, we've done it to survey data. We're going to describe how we've been able to create sex and gender-informed resource and engage with a multidisciplinary hub. And we hope that this will really help set the foundation or continue your learning around sex, gender, and sex and gender-based analysis and how it can be applied in your work. I'm now going to pass it over to my colleague, Andrea, who's going to walk through sex, gender, and cannabis use.
Thank you, Lindsay. Thank you, everyone, for joining today. In this section, as Lindsay said, we're going to talk about sex, gender, and cannabis use. So as you can see in this image, it's a really great image because it shows that sex and gender are two different concepts. And according to the Institute of Gender and Health, every cell is sexed and every person is gendered. So what does sex refer to and what does gender refer to? Sex refers to a range of biologically based factors, characteristics, and processes that affect human health, such as genes, anatomy, physiology, metabolism, and neurobiology. And you'll see in the next slides that we have a diagram. We have actually two diagrams, one for sex and another one for gender, where what we usually do is we break this down into components, and we're going to talk about these separate components for sex and for gender. And gender refers to a range of social and cultural factors and processes that affect experiences of health and healthcare, such as gender roles, relations, identities, and institutional practices. And although we talk about them separately, many times what they do is they interact and intersect with each other and with other characteristics. So how do sex, gender, and equity matter in the substance use field? So the short answer is in multiple ways. We know that they matter only if we conduct a sex and gender-based analysis. And we're going to talk about this as well. And why we do this process is to see that sex and gender actually are among the most influential of the determinants of physical and mental health. And they matter in the mechanisms because there are different mechanisms involved in processing substances, different substances such as nicotine or cannabis in this case. And these mechanisms affect the biological responses to drugs. We also know that there are different consequences and impacts for men, women, and gender diverse people. And there are also differences in pathways, risk, and protective factors, progression, transition, and maintenance. And of course, they are also involved in treatment issues. And men and women and gender diverse people have differences in access, readiness, retention, and outcomes. Okay, so these are the diagrams that I was talking about before. It's important to examine all components of sex and gender and measure them, analyze and reporting on them, because this increases precision and prevention, research and treatment. And these diagrams are very useful because it shows that there are different components and we can break down sex and gender into these components. And for example, we know that hormones affect reproduction, mood, and metabolism. Genes affect disease, susceptibility, body functions, and therapy. Neurobiology is involved in pain, memory, cognition, and mental health. And physiology and anatomy affects responses to medication and substances. And as you can see in this diagram, the one on the left, they interact and multiply and combine their effects. So sometimes we don't know exactly what's first, if it's the hormone or the physiology or the anatomy. But we know that there are sex related outcomes. And gender, the one on the right, is cultural and temporal and intersects and interacts with other characteristics such as sexual orientation, race, ethnicity, religion, culture, age, nationality, and ability. And for example, gender-related factors influences and can heighten dominant understandings of masculinity or femininity. And this can be expressed in intimate partnerships, peer groups, friendships, or families. And in the next slides, we're going to talk about some outcomes and the differences for men and women. So, what does the evidence say about sex and cannabis? We know that in some cases, males may experience more cognitive and memory impacts. However, the evidence is mixed. What we know about females is that they transition from initiation to regular use faster than males. And this is similar not only, I mean, this is specific to cannabis, but this happens with other substances. And we refer to this term as telescoping. So when you hear about telescoping, this is what we refer to. There is some evidence of higher sensitivity to the subjective effects of cannabis in females compared to males, particularly at low doses. And what do we know about gender and cannabis? So what we know is that when girls are asked about cannabis use, for example, their answers suggest that cannabis is used as a way of resisting dominant feminine ideals. Women are more likely than men to obtain cannabis from friends and family. Many women report stopping cannabis use when they transition to motherhood. And men are more likely than women to drive within 2 hours of using cannabis. Also, boys and men report experimenting with more routes of administration and have higher rates of smoking and vaping. And when we look at other variables that intersect with gender and age, for example, Canadians age 65 and older are less likely to consume cannabis than younger Canadians. And among those who do it, they are generally more likely to consume it for medical reasons. So we're going to talk about the Sex, Gender, and Cannabis Hub, and this project has been developed by the Center of Excellence for Women's Health, a research and knowledge exchange center focused on sex and gendered approaches to health, rooted in policy, practice, academic, and community networks. We developed this project in order to fill a crucial gap in Canada on the latest evidence on sex, gender, and cannabis. And we also wanted to provide reliable and up-to-date information on sex and gender-related factors affecting cannabis use to guide service provision, research, policy, and individual health decisions. So what we did during the development of this project, we took an iterative approach and we combined information from multiple searches, analysis, and knowledge keepers. These approaches are a literature review of the latest evidence, analysis of survey findings in collaboration with the International Cannabis Policy Study, and input from community advocate service providers, researchers, and policymakers who met regularly in virtual communities. The Sex, Gender, and Cannabis Hub is the resource where we house information from our findings as a centralized way for researchers, policymakers, healthcare providers, and community members to access this information. And this material has been released monthly. This is material that was created by the Center of Excellence for Women's Health. And we also link resources from other organizations that do sex and gender-based work in relation to cannabis. So now I'm going to talk about the sex and gender-based analysis that I mentioned before, and it's in relation to survey data. So you heard me talking about sex and gender-based analysis before, and this is an analytic process that, when applied to health, involves assessing programs, policies, treatments, prevention, messaging, and health promotion for differential impacts on people based on sex, gender, and a range of diversity factors, with a view to tailoring such efforts to achieve more equity. The process of doing SGBA plus is iterative, meaning that each stage builds on the last process or step, and it involves defining the issue, describing the population, assembling the evidence, analyzing the implications, and structuring recommendations. This is what we talked about in the previous slide. We conducted different searches, and we screened that all the literature that we found, and we analyze it from a sex and gender perspective. Also, before, we talked about how sex gender related factors intersect with other variables, and they are not, so sex and gender related factors are not homogeneous across populations or sex or gender categories. And that's why we need to consider these interactions between a range of characteristics, such as the ones in this diagram. So in the middle, what you see is the unique circumstances of a person, and the second circle from inside represent aspects of identity, as education, class, for example, disability, religion, language, social status, health status. And the third circle from the inside represent different types of discrimination or attitudes that impact identity. And the outermost circle represents larger forces and structures that work together to reinforce exclusion in some cases. These multiple forms of oppression are simultaneous and cannot be separated from experiences of sex and gender-based discrimination. Okay, so just to set up the stage for the next slides and for what we did in the Sex, Gender, and Cannabis Hub, in a previous report, in a previous project, we looked at different surveys, cannabis surveys conducted here in Canada. And we saw that usually, although we talked about all those components of sex and gender, usually surveys do not include these aspects. Usually what they do is they include sex and gender, and sex is asked based on male-female categories. And gender is often just about gender identity and asked as men, woman, gender diverse, non-binary, trans, and usually surveys also include these options: refuse to answer or don't know. Although I think with sex-related factors would be more difficult to include them in surveys because of the nature of the survey. Gender roles, identity, relations, norms can be broken down and measured using validated indices, but surveys don't often do this because they will take longer, and also because they will have a higher price. And we saw that sometimes secondary analysis of these surveys or databases are highly relevant for sex and gender-based analysis and how it works and cannabis research. And we think that the surveys could include more aspects and other variables that I'm going to talk about in the next slide. So based on this report that you can consult on the Sex, Gender, and Cannabis Hub, and the link is there in the slide, we recommended a few things. We recommended the addition of socio-demographic variables such as sexual orientation, cultural background, or immigration status, and time spent in Canada to Health Canada surveys when possible. And in this case, I think we finished this project in 2019, and in the next survey in 2020, Health Canada included the question on sexual orientation and the immigration status into the Canadian Cannabis Survey. We also recommended the introduction of questions related to the general health, mental health, depression, anxiety, because they have a differential impact on women and men and gender diverse people, and because we know that they also respond in a different way and they are affected in a different way. And also additional questions regarding characteristics that have been linked with cannabis use, such as use among family and friends. Okay, so in our collaboration with the International Cannabis Policy Survey, what we did is, and Lindsay will walk you through the hub later, we collaborated with them and we created these bulletins. What you see here is the variables for bulletins 1 to 4. So in these bulletins, we analyze the cannabis use status, the age of initiation, the province, and the past 12-month use, the sexual orientation, the race, ethnicity, sex, gender, and race, ethnicity, because we are also interested in these intersections between gender and race, ethnicity, and sexual orientation. And in the bulletins 5 to 7, we analyzed the variables: driving a vehicle within 2 hours of using cannabis, being a passenger in a vehicle driven by someone within 2 hours of using cannabis, routes of administration used in past 12 months, using cannabis for pain relief instead of opioids or prescription pain medication, and cannabis used to improve or manage mental health symptoms. And the last one would be cannabis used to improve or manage medical health symptoms. So there are some differences between the International Cannabis Policy Survey, how sex and gender were measured, in the wave 1 and how sex and gender were measured in waves 2, 3, and 4. In wave 1, respondents were asked their sex and their options were female, male, and gender identity. They were given these options: female, male, transgender, do not identify as female, male, or transgender, other, though no, refuse to answer. And the ICPS changed it in the next waves. And in the starting with wave 2, respondents were asked their sex and they were given the female, male, intersex, and unstated option, and gender identity using the following responses: woman, man, other, and unstated. So these are the bulletins that, these are the covers of the 7 bulletins that we published, except for bulletin number 7, and that you can find on the hub. The first one is how do men and women report patterns of use? So it's very general. How does sexual orientation affect patterns of use is the second one. So here we intersected gender with sexual orientation. How do race and ethnicity affect patterns of use is the third one. What substances are commonly used on the same occasion as cannabis? The fourth one. We were also interested in the roots of administration for the fifth one. What are men's and women's driving behaviors after cannabis use? The sixth one. And the last one that we're going to publish very soon is how do women and men report medical cannabis use? In terms of what we found, there are some interesting results that we also saw in the next slide, please. Thank you. That we also saw in the literature. We saw that more men than women reported using cannabis, and they use it more often. There are also people that do not use cannabis. So, for example, we saw that more than 4 in 10 respondents reporting never using cannabis, with more women reporting never use than men. Men were more often weekly or monthly cannabis users compared to women. We also saw that part of the telescoping process, or although we didn't have the second part of it, we saw that women initiated cannabis use at a slightly older age than men. 9% of respondents reported daily or almost daily cannabis use, with no significant difference between women and men. And in terms of the province, we saw that men from Ontario, Quebec, and Nova Scotia reported significantly higher rates of cannabis use than women in the past year. This will be the summary for the first 4 bulletins, and this for the bulletin number 5, 6, and 7. And we saw that more women than men prefer edibles, cannabis oils or liquids taken orally, and topical ointments as well. More men than women prefer dried herb, concentrates, hash, and drinks. More women than men reported having used cannabis for both medical conditions and mental health conditions. And more women than men reported having used cannabis for pain relief instead of opioids or prescription pain medication. So overall, after conducting this secondary analysis of surveys and using a sex and gender-based analysis plus, what we saw is that language and terminologies are important because in some cases, findings are difficult to compare due to inconsistencies in the definitions and questions regarding sex, gender identity, sexual orientation, racial, ethnic groups, and other categories used. Also, there is a narrow interpretation of gender, and usually surveys focus on gender identity, ignoring norms, relations, and institutional gender. The sample is very important because sometimes, and we also found it in our case, some samples are very small and it's very difficult to conduct analysis due to this fact. And this also adds to the intersections, because if you want to conduct analysis on intersections with small samples, it's a little bit difficult. So what did we learn? So overall, as with most substances, men use cannabis more than women, regardless of sexual orientation and racial ethnic groups, and they also start at a younger age. Women use for medical and mental health conditions. Men and women prefer different routes of administration. Trends in use by gender and or sex are important to examine and follow over time and post legalization. We haven't conducted any analysis on this. We didn't compare results from 2018, the first wave, and post legalization. And further research and more precise methods on sexual orientation and race, ethnicity, and sex gender will lead to a deeper understanding of differences. And this will also help tailor interventions and strengthen health promotion initiatives by sex, gender, race, and sexual orientation.
Thanks so much, Andrea. I think you did a really great job of explaining, why SGBA is important, but also many of the challenges, keeping in mind this was a secondary data analysis. So we were looking at, a different body of research and really trying to apply these principles onto it. And so as we continue through today's webinar, we're going to talk a little bit more about how we can create resources that equally keep these notions in mind. So, as Andrea mentioned, this project was very multifaceted. We did the secondary analyses of the ICPS surveys, and then we also were doing consistent literature reviews. And lastly, we had this community, or we had 3 communities of inquiry that we closely worked with. And so we were able to apply these principles of sex and gender science and sex and gender-based analysis in all of these different areas. When we were looking at the literature, we were regularly running literature searches so that we could get the most up-to-date evidence on sex, gender, and cannabis in order to create these knowledge products. And we were really able to look at a variety of topics. So we have this one on beliefs and perceptions, which describes how beliefs and perceptions about cannabis vary by gender, how messaging about cannabis is received, and how that information can be helpful to service providers when having conversations about cannabis. I think that's also really helpful for policymakers who might be interested in labeling for cannabis use, for instance. So we were really looking at creating summaries with high levels of applicability for practitioners. Some of the things that we found specifically, sorry, Elle, I'm just going to get you to go back. Thanks. Some of the things that we found specifically in this particular research summary, again, really highlighted that these perceptions and beliefs varied by gender, and men were less likely to perceive adverse effects of gender use for a range of health issues and activities. So in one example, a Canadian study of college undergrads published in 2019, as we were beginning this project, found that men were more likely to report that they believed cannabis was safer than alcohol, and more likely to believe that cannabis was safe to use during pregnancy, when driving, and that's in comparison to women. And I think that was, as Andrea said, a lot of what we saw in the analyses were also reflected in the research. So just in driving alone, we can see that evidenced. Another key message that we saw in this particular research summary was the importance of healthcare providers effectively conveying information about risks and benefits of cannabis use, especially regarding pregnancy and reproductive health. And another Canadian study found that women did not believe that cannabis could pass through the fetus, and they were thus more likely to seek out health information about cannabis and pregnancy from the internet or friends and family. And so what's the importance of relationship building? And we were able to take some of those ideas and further translate that into useful resources for providers. In the next research summary, or one of the next research summaries, we really heard the interest in folks understanding the links between cannabis anxiety and depression and what that looked like when, again, you brought forth the literature on sex, gender, cannabis, anxiety, and depression all together. And it really highlighted how mixed the evidence remains on the associations between sex, gender, depression, anxiety, and cannabis use, and how we really don't have strong enough evidence on whether cannabis use causes depression or anxiety, because there really have just not been enough studies with human participants. But some things that we did find were that among young men, there might be an association between cannabis use, depressive symptoms, and a diagnosis of depression. And among young women, there may be an association between cannabis use, depression, anxiety, but not symptoms of depression or anxiety. And there might also be an association between cannabis use and suicidal thoughts and attempts, more so among young women. One thing we hear a lot is that cannabis is used, particularly during pregnancy, as a safer alternative to other pharmaco options for women who are experiencing anxiety and depression. But that evidence still remains quite mixed. And so we really aren't able to report on it, but we do see that in couples trying to conceive, that there is an association between cannabis use, anxiety, and depression symptoms. And we do see that among trans and gender diverse folks, that there is evidence of depression and cannabis use, particularly among trans and gender nonconforming youth who experience self-harm. Lastly, what we can see is that brief interventions, same with when we're thinking about beliefs and perceptions, brief interventions really remain a promising practice, and they can be helpful not only in reducing cannabis use, but also in reducing or managing anxiety symptoms among both men and women. And so I think that's a really important strategy that we can think about as we move forward. The other resources that we were able to create were really developed out of our 3 communities of inquiry. And we were really trying to create resources that would be most helpful for them. So in one community of inquiry on women's substance use treatment, which I'm so glad to see some folks from that COI here today, we heard the importance of creating resources that both women and service providers could use that explored why women use cannabis, such as to help manage pain, to cope with anxiety and depression, to relax. And this was really seen as a sheet that either service providers could use with women directly, or that women could use themselves, and includes questions about that women can use to reflect about reducing harms. And so really using that as a prompt for discussion to help normalize these conversations. There also remain a lot of questions about routes of administration. So we were able to think about sex and gender in that capacity. And we were able to create this sheet that was informed by the Canadian Cannabis Survey and all of the literature that we had explored, that looked at both the prevalence of use, which you can see in those larger circles, but also what some of the health effects may be, so that way women could make more informed choices about their use. And it included reflection questions as well, so that way women could think about the benefits and harms perhaps they were using for pain management, and could see this sheet, and that maybe smoking wasn't the most useful ROA for them. Maybe another ROA would have been more beneficial for the reason behind their use. And lastly, recognizing that the second most common reason for use in literature following pain management was to cope with anxiety and stress. We created this sheet that providers, again, can use with women, or women can use themselves to help find alternatives to use, whether it be grounding, mindfulness practice, walking, or recognizing social pain and avoiding dependence. And so whether our COI was and the women's treatment facilities were working from an abstinence or harm reduction focus, this is something that they could use, creating sort of healthy coping mechanisms in lieu of cannabis or other substance use. We also heard for the need for resources specifically around breastfeeding, that perhaps there was more that was being developed on pregnancy, but there hadn't been a lot about breastfeeding. And so we created 2 resources, and this one was the first one for health and social service providers. And we include information about what is known about cannabis and breastfeeding, examples of how to reduce potential harms of using cannabis, perspectives of women who vape in the perinatal period, and strategies for advocating for families with substance use concerns who may also experience child welfare involvement. And for example, in the key messages, sorry, Al, I'm just going to get you to go back again. In the key messages page, we answer some common questions about the safety of cannabis and information you can share with families, such as answering if cannabis can be passed to babies through breast milk, the effects of cannabis on breast milk, and if cannabis affects breast milk production, and what parents might need to know about cannabis use in breastfeeding. We also, Ella, I can get you to move to the next slide now. We also really wanted to create a page that could help when we're engaging in these conversations, when we're thinking about brief interventions. And so having this really pragmatic section that really allows you to have open and supportive conversations, thinking about asking questions, being curious, being trustworthy and respectful, and offering ideas and providing space to discuss many options, approaches, and supporting people to make safer decisions. In the subsequent pages of that resource, we also offer strategies for harm reduction, including avoiding being around secondhand smoke, using cannabis with lower amounts of THC, or using cannabis less frequently or in smaller amounts, so that because we know that the effects of cannabis are dose related. The next resource we created, we tailored directly towards women. It certainly really benefited from having these communities of inquiry and quite critically reflecting on gender and everything that gender means. As Andrea said, often we're thinking about gender identity, but creating a resource that thinks about norms, roles, and relations was really quite powerful. And unlike the resource for healthcare providers, which was specific to cannabis use, this resource was actually inclusive of multiple substances, including alcohol, caffeine, nicotine, opioids, cocaine, heroin, and other street drugs, because we recognize that often folks aren't using one substance. Cannabis is also often used with alcohol and tobacco. And this resource includes plain language information about what's known about breastfeeding and substance use, tools and activities to help think about breastfeeding plans and goals, information about trauma, harm reduction strategies, and ideas of what folks can talk about with their trusted healthcare providers. And we really wanted to create resources that allowed women and people who are lactating to think about different areas of their life and what effects substance use can have. So on the next slide, we show one of the activities that we put in that asks, what role did substance use have in your life before becoming a parent? How has it changed over time? In what way do you think substance use will affect parenting? And so folks are able to think about their substance use in relation to those questions and in relation to all of these categories. So really prompting reflection. We also include activities thinking about who's in people's circles of support, realizing that all of us have different life experiences and may have different folks that we trust and rely on, and also activities of pros and cons of substance use while parenting. And as we walked through this resource, we really got a lot of feedback about what potential benefits and drawbacks could be when parenting, including that both substance use could reduce stress, but it also could have the potential to lead to questions about child welfare involvement. So balancing those pieces together. So bringing us all back together, we talked about what sex, gender, and SGBA plus are. Andrea walked through what SGBA plus of the surveys look like. We've shared resources about the literature and what it looked like to create sheets. And what we did is we actually put all of this onto one website. We have a multidisciplinary hub that really explores sex, gender, and cannabis use. And Ella, I'm just going to get you to click again. Perfect. So the hub includes all of the information and resources we've shared today, including survey bulletins, research summaries, information sheets, and booklets. And this is what you'll see when you get to the home page. Throughout this entire project, we really recognize that people want more information. And while there is information about cannabis use, and it's increasing particularly in our post-legalization context, it doesn't necessarily consider sex and gender. So creating this hub of collated materials allowed us to continuously respond to the patterns we were seeing in literature, the needs from service providers, and priorities from policymakers, women themselves. If you click on the next slide, you'll also see these different icons. So in each each of the icons that you saw on the home page includes these subpages. The site is accessible. It includes materials available in English and French. And so as we wrap up today, I'll just quickly describe these categories and what you can find. And so in the sex and gender page, you might find resources about the social and cultural aspects of gender, about all of the surveys, for instance. In the beliefs and attitudes, we include resources about the gendered perceptions of cannabis use, which routes of administration are preferred, and how cannabis use affects individuals differently or the same depending on their sex and gender. And really, again, diving into beliefs and attitudes around cannabis use. The last two that I'll mention, we know that there's a lot of curiosity and interest in reproductive health. So we do have resources about pregnancy, breastfeeding, the preconception period as available. This evidence remains very mixed. So that perhaps is my caveat there. And so we don't have any answers. We don't have any definite answers about cannabis and pregnancy, for instance, but everything we have been able to create or have been done in the last few years are available on that page. And lastly, under the tools and information page, you can see resources that we've created, such as the booklets, other really practical, tangible resources that, that folks can look at. Now, I know that there are a number of questions in the Q&A. Before we finish up, we're just going to put up one poll. Just asking 4 quick questions. So we'll give folks about a minute or so to answer the poll. And we so appreciate those that did know about the hub before and those that didn't, and that both groups are here and represented today. That's really wonderful. Thank you so much.